Good morning, all. Thank you, Dr. Kala, for the invitation. So I'll start. No financial interest on any companies. So it's basically it's a minimally invasive laser vision correction, reformed as keratolendicular extraction. These are new machines. Already Dr. Kala has explained regarding this. So I'll be talking about Max 500 and 800. So it's from Carl Zeiss, and the laser specification, just minimal details. The laser wavelength is around 1043 nanometers, and the pulse duration frequency is around 5000 kilohertz for the 500 and 2 megahertz for the 800. So the energy per pulse rate is 110 nanojoules to 150 nanojoules, and the laser spot size is 0.5 microns to 1 micron diameter. And it's a 3D placed distance of around 2 to 5 microns, and it's a spiral shaped delivery. So the mechanism is basically the ultra short lasers powered high power pulses at a very high speed, and bonds between cells broken by photo disruption, resulting in micro gas bubble creation, creates tissue cleavage, resulting in a precise tissue transaction at the focus plane within the cornea. So these are normal dimensions we used to keep. Depending upon the pupil size, the optic zones can be customized, and the flap diameters is 0.5 to 1 mm oversized to the optic zone, and the cap thickness is ranges from 100 to 120 microns, and the side cut is 2 to 5 mm placement at 90 and 180 depending upon the surgeon's convenience, and the refractive correction determines the size and shape of the lenticule. So this is the cross section, lenticule, vertical cut, cap cut, and the last side cut. So the main benefits are, it's a convex shaped lenticule. The subbasal nerve plexus relatively spared, and the subepithelial plexus are also spared. So dryness is comparatively lesser than LASIK, and the stromal innervation dents at the periphery are not affected. So corneal sensation is better, and the iatrogenic dry eye is less. So these are the clinical data which I have. I've been doing SMILE for the past 8 years, and the visual acuity, accuracy, contrast sensitivity, corneal strength, stability, dry eye, and safety. So this is a article which is published in the JCRS, where there is a visual outcome of SMILE versus LASIK, and the 96% of the patient achieved 6 by 6 or 20 by 20 vision within in a span of 3 months, and whereas in LASIK it is 92%. So in conclusion, the 3 months result demonstrate the refractive accuracy, dry eye, contrast sensitivity, and the induced aberrations are better following SMILE rather than LASIK. So in the higher order aberrations, the conclusions are the induction of the higher order aberration after femtolasic and relaxed smile was small and similar when compared to two techniques. In a study comparing smile with the LASIK, the higher order aberration and spherical aberration were significantly lower in smile cohort. And in contrast sensitivity, neither mesopic nor photopic contrast sensitivity show any significant changes. So in conclusion, relaxed smile produced satisfactory refractive outcome with unaffected contrast sensitivity after 1 year. And the corneal hysteresis and the corneal resistant factors, in conclusion, the flap based LASIK and the relaxed smile, clex and the relaxed smile results in the similar reduction in corneal biomechanics when evaluated with Corvus and ocular response analysis. So however, the mathematical modulation suggests that stromal tense strength should be stronger with smile compared to LASIK, is because the anterior corneal stroma is not affected. So in case of regression, the considering long-term predictability and the stability, 89% of the eyes were within the 0.5 diopters and 100% were within 1 diopters of intense refractive target in a duration of 5 years. So in conclusion, the long-term data also suggests that the SMILE has a excellent stability. So in case of dryness also, the reduction in subbasal nerve plexus and the nerve density are significantly less in SMILE treated eyes than femtolaser LASIK treated eyes. This is a span of 1 week, 1 month and 3 months respectively. So this also defines that comparatively dry eye is less in SMILE than LASIK. So this is a confocal microscopic image of smile versus LASIK in a 1 week, 2 week and a 4 week scenario. The upper one is the smile and the lower is the LASIK, where you can see the subbasal nerve plexus are preserved. And in safety, they demonstrated after 1 year, smile is as effective, predictable and safe, minimally invasive corneal refractive procedure. So in astigmatism also, in certain condition, if you have a cyclotorsion machine like the 800, the absolute angle of error was significantly lower for smile compared to PRK. Possible reason for this is better centration in the smile that is maintained via continuous suction. In comparison, analysts with smile and LASIK report that decentration in smile in which was affected the overall alignment of the astigmatism treated. And these are the contraindications for CLEX. Corneal scars, family history of keratoconus, eye rubbing, corneal ectatic disorder, as same as the refractive analysis. And in pachymeter less than 480 microns and RST less than 260 microns, you can consider doing a smile extra procedure. So in what you do is smile extra is it's a simultaneous cross-linking has been proposed as an adjunctive therapy to corneal refractive procedure to prevent future ectasia, especially when performed in a borderline corneas. So risk factors such as thin cornea, abnormal topography, history of eye rubbing, and a family history of any keratoconus or pregnancy or hormonal imbalance, you can consider doing smile extra. So what is done? So a normal smile is done, followed by 0.23% of riboflavin in saline injected into the interface and allowed to diffuse for 60 seconds, which is then rinsed with balanced salt solution, and a UVA radiation is performed through the cap using a 45 millivolt per centimeter square for 75 seconds, delivering a total energy of 3.5 joules per second centimeter square. So in conclusion, higher power correction, anterior stroma is not affected, and less higher order aberrations, less higher order aberration, and biomechanics are less affected post smile, and simultaneous cross-linking in borderline cornea, and the iatrogenic dry eye is comparatively less, and the wow factor like the post-op day till day 1 itself patient attains a 6/6 vision. So this is just a video. So this is done in Visumax 500. The visual axis is aligned in the center, followed by the femtosecond lasers are starting with the posterior cut, followed by the anterior cut, the vertical cut and the side cut, and the patient is brought to the Zeiss microscope, and the side cut is identified, and the dissection is executed from posterior and anterior and posterior. Followed by the lenticular extraction. Thank you.